Couple things before this slipped my mind. One is that, if you're working like in an ER or whatever, you get a patient that's got, some of your doctors will order everything. So they've got upper extremity injury and they may order, from fingers all the way up to humerus. And some things you might be able to kind of combine, like hands and fingers, but some things you absolutely cannot. And because of the convergence of the central ray, you can't do an AP and lateral. Let's say you get an order for wrist bones, the forearm, and elbow. Because of the divergence of the central ray, you can't do all those in just two views. You got to do each one individually. Because you're going to get so much distortion on proximal and distal end that it's not going to be a good study. Okay, so you have to do them individually. That's one thing. And the other thing is that, again, the elbow is a complicated joint, and sometimes you can take an injury to it and not be able to move it completely. So if the patient, you try to coax the patient into getting their elbow completely extended and they just cannot do it, you're not going to force them, but you do have options. All right. So if a patient just absolutely cannot or will not extend their elbow, on the flip side of the tough patients, you got patients who they're just not going to be compliant at all. Right. So if you've tried to talk the patient into straightening their elbow out and they just absolutely won't straighten it out past about that, then what you're going to wind up with is an obscure joint space. So you can see the joint space between the radial head and the capitulum, right? It's a light area right there. So if the elbow is bent, that's going to close up. Okay, it's important to see it. So what we can do is we can do kind of a composite view, so to speak. So in partial flexion, what we can do is two views to make one. So what we would do then is to shoot one with the radius and ulna parallel to the image receptor. All right, and that would give us that. But the problem is our humerus, the distal portion of the humerus, is now at an angle, which is going to give us foreshortening and distortion, right? So we're going to do two views, one with the distal humerus parallel and one with the radius and ulna parallel. Okay, so it'd be, if the patient can't straighten their elbow out, you would do two APs, one here, right? One with the humerus parallel and one with radius and ulna parallel. Two APs. The patient can't straighten their elbow out. They're ugly x-rays, they just don't look right. And that's the distal humerus. We just can't see the radial head, and the olecranon is just all obscured. And then we've got the proximal portion of the foot on that. So not pretty. We get a significant amount of soft tissue superimposition that just kind of obscures everything. But again, if the patient just cannot accomplish what you need them to, that may be your only option. Okay. So this is coil method. Coil method is not on the test. So you're going to spend how much time studying the coil method? Zero. Right. And I'm going to do this every one of these that comes up because sometimes we have students just they get home and they forget about it. So no coil, you'll study it next year. So your humerus, again, we're going to do AP and lateral, and the positions we can use for the lateral, we've got a few. If the patient has a suspected fracture, you're just not going to move it at all. All right. But the preferred positioning for humerus would be have the patient in an anatomical position, so that will give us the external rotation, right, which is going to give us our greater tubercle on the lateral side, right? Greater tubercle on the lateral side and supinating. Okay, that's going to be our AP. Couple of things about it though, you might want to have the patient extend their arm away from their body just a little bit to try to get rid of the soft tissue overlap from the upper portion of the chest. And the other thing is that you've noticed that you don't really have to set technique on most of your, unless you're doing portable, on most of your exams, right? You push a button that says AP or PA chest X-ray, and it sets everything up for you. That's hard to do for AP humerus. And the reason for that, and we're going to dip just into physics for just a few seconds. Your radiation detectors are not much smaller than your phone. All right, so they're pretty, they're relatively large, I guess I should say. So let's say they're this big, right? So they're that big. The way those things work is they count X-ray photons. Okay, there's an ionization chamber in there, and when X-rays pass into it, it ionizes the air. And you know what ion is, right? So it ionizes the air, and then it counts the ionization, so it can tell how many air molecules inside just they get ionized. And whenever the proper number get ionized, it sends a signal over to the timer circuit to turn off the exposure. It's what we call automatic exposure control. You'll hear those detectors referred to as ionization chambers or phototimers, photocells even. They all mean the same thing. Excuse me. And in order to get the proper exposure, the proper amount of ionization so that you get the proper exposure, so you get the proper image, is you have to put the anatomy of interest directly over that cell. Okay, so you're looking at this, and if we're doing a humerus, what's your anatomy of interest? Humerus, right? Again, not rocket science. It's a humerus, right? So how wide is your humerus compared to this? Not as wide, right? So is the soft tissue going to absorb some of the X-rays and kind of add to, the formulation of all that? And the answer is yes. But now imagine you've got a patient who's very thin, and maybe their bone is smaller than that, and now you've got to perfectly position this thing. This patient's standing here like this, right? You got to perfectly position this thing diagonally across a photocell. What's your likelihood of doing that? You can do it. It's going to take a lot of work, right? You're going to have to be pretty precise and count on the patient not moving. Okay, so this is the first exam that I will suggest that you could do. Use phototimer. Suggest you not, because it's just going to be difficult to make that happen. Alternatively, what you can do is whenever you go into clinicals tomorrow, take a look at your control panel and all the different settings on it. And what you should see, apart from you push the button, it gives you KVP, MA, time, the photocell arrangements, but you should have two buttons that have like pluses and minuses on them. Or it may be a series of buttons that have different pictures, or different pictures of different size people on them, right? So you look at that and you think, okay, that's hypersthenic patient, that's asthenic patient, that's what it is. And what those things do, what those buttons do, is they recalibrate that cell. So it increases or decreases the amount of radiation it needs to give you the perfect exposure. Sounds complicated, right? It's not that complicated though. What the point I'm trying to get to is this, right? Since you've got a situation where you're going to have a difficult time completely covering your radiation detector, you want to recalibrate the radiation detector and tell it to give me more ionization before you turn off the exposure. What that means is you're going to hit the plus buttons. You're going to hit the hypersthenic buttons, even if the patient is not hypersthenic. Okay? So if you're going to phototime, that's fine. Just do that. Okay? And if you get a good exposure, you make your exposure, you look at your index number, everything looks good, then you're going to have to repeat that for the lateral. And what I would recommend that you do is pay attention to what your mask shot out with, turn off the photo timers, and set your technique for the mask. It's going to be the same technique. So your AP is going to be, again, externally rotate, put the humeral, I almost said femoral, humeral condyles parallel to the image receptor. Test question. Humeral condyles parallel to the image receptor. Puts the greater tubercle in profile on the lateral side. Okay. Abduct the arm just a little bit to get rid of that soft tissue superimposition. For your lateral, if the patient can do it, just take their hand and put it on their hip. All right, just take their hand and put it on their hip. Now, if we're looking for two views 90 degrees from each other and our humeral condyles will parallel for the AP, what's our orientation going to be for lateral? Perpendicular, right? So that's what you want to do, is put those perpendicular to the image receptor. What you're going to see some people do is put the hand, have the patient hold the hand like so. That's fine. You might get some distortion. The distal end might not be in contact with the image receptor. So if you put it on the hip, you can, you can put it back a little bit further and put everything up against the image receptor. If you have a patient who comes in and they've already got their arm like so, they're already pretty much in a lateral position, right? So if you can get their hand on their hip, that's great. If not, you can shoot it the way it is, but you're going to have some distortion. Or you can even turn the patient around. Since their hand is already here, you can even turn the patient around and shoot the end. That's going to be a non-routine projection, right? So to keep the radiologist from thinking that you mismarked the image, you might want to mark that you shot at PA instead of AP. Okay, so just options. AP, externally rotate, right? And we see the greater tubercle on the lateral side. Internally rotate, we see the lesser, I said the inside, the outside, the greater tubercle on the outside on the external rotation, lesser tubercle on the inside on the internal rotation. Okay. But if the patient's definitely got a fracture, let's say that the patient comes in and they're holding their arm, they say, I can't move it. And you make your first image and you see a fracture. Then you're not going to move it. You got to do something else to get a lateral. So you got a couple of different options. To see the distal end is pretty easy. It's not a textbook. This is an image receptor. All right. So what you're going to do is take the image receptor and you're going to slide it up under the patient's arm as far as possible and make sure that you have the patient hold that image receptor. Those things are expensive. The machine that's upstairs right now, when we bought it, they told us have patients, the students be real careful with the image receptors. They're $100,000 a piece. So be careful with them. Okay. So instruct the patient, hold on to this thing. Okay. So what position would that, if the central ray is coming from that direction, what position are you pretty close to in right here? Pretty good lateral, right? Are you going to see the proximal end though? No. So you got to do a couple of different things. One of a couple of different things. So the first one is that you can do what we call a transthoracic. A transthoracic means that you're going to shoot through the thorax to get the proximal portion of the humerus. So what you're going to do is to make sure you don't lose sharpness of recorded detail. You're going to turn the patient towards the affected side. So you're going to put the affected side up against the image receptor. Okay. Yeah. Elevate the non-affected side, and you're going to shoot through the patient's all the way through the thorax. You're going to have a ton of superimposition in doing that, but you can get rid of some of that. Okay, so a lot of what we've told you, have a patient be still, have a patient hold their breath, minimize motion, and all that. Well, forget about that for the transthoracic. We're going to use that motion to try to blur out some of the things we don't want to see. Okay. So we're going to get the patient, like in a lateral chest x-ray, the affected arm, have a patient hold it however they want to, make them a sling if you need to, right? But they're going to take the unaffected arm and they're going to elevate it. You're going to shoot laterally, just like a lateral chest x-ray, just get that one arm out of the way, shoot like a lateral chest X-ray. It's going to be with lower KVP, higher mass value. And what you're going to do is you're going to just let the patient breathe throughout the exposure. It's what we refer to as a breathing technique. That humerus is not going to move much. Okay, it's going to move a little bit, but it's not going to move much. But what's going to move a lot are the lung markings and the ribs, and it's going to blur those out just a little bit so that you can see the humerus a little bit better. Okay, we're going to use breathing technique here. We're going to use it on the T-spine. We're going to use it where else? Sternum. So we're going to use it a few times. Okay, but your best bet is to watch the patient and just not say anything. Okay, so you get them positioned, you rotor up, and you watch them. Some of your patients have had a lot of X-rays, and as soon as they hear the rotor, they're going to stop breathing. So if they do, you just say, no, I want you to just breathe normally. All right. But if they don't, if you can tell that they're still breathing, just try to catch them at the end of one inhalation or exhalation, so that you get maximum motion of those structures, the ribs and the lung markings. Okay, so here's the rub, though. Okay, so this is external rotation. You can tell because it looks kind of like an AP of the elbow. Internal rotation looks kind of like a distorted lateral of the elbow. Okay, so that's cool. I don't see the others. Okay, so here's the rub on the AP and lateral humerus. So again, your patients can be pretty tough. One of the toughest patients I ever had was like maybe a 12-year-old girl, and she had a obvious fracture of the humerus. It's like she had an extra elbow, and she was just moving this thing all over the place. It didn't seem to affect her. It wasn't a trauma. She had a bone cyst, and a bone cyst just weakens the wall of the bone, and she had a pathological fracture. It wasn't cancerous. It was just a bone cyst, and it snapped. And I don't remember what made it break, but she was just moving all over the place, and it was humerus. So if we told her externally rotate your arm, and you're not going to say it like that. You can say, I want you to roll your elbow out like that. Make your hand like that. She'd do it, right? Even with broken humerus. And then for the lateral, if we said, I want you to do that, she'd have done it. So here's the thing, though. If you have one of those patients, and let's say you don't know that they've got a fracture, you externally rotate the elbow, right? You externally rotate the hand to get a good AP, then your humeral condyle is parallel to the image receptor, right? So one benefit of DR is you get immediate feedback. You can see right away if a patient's got a fracture. With films, we didn't get that. We had to process the films, wait 90 seconds for every film to fall. So we didn't know. We shot a full series before we ever knew anything was going on. With DR, you see right away. So let's say you shoot that and the patient has an obvious fracture and you go, oh, relax. And the patient grabs her arm like this. So what are you going to do? They've got an obvious fracture. What's that? Keep it like that. Transthoracic? Is that what you said? Sure. Yeah. That usually means no, I did not. All right, so that may be what you're thinking. Okay, so you got the patient, and we're going to put the image receptor up under the patient's arm. Do the distal portion, and then do transthoracic. Here's the problem with that, though, is the patient's humeral condyles are parallel for the AP, right? And then if you have the patient do this, and then you turn this way, how are my humeral condyles? So whatever position you're in for the AP, your humerus needs to be in the same position for the lateral. Okay? So if you get the patient here for your AP, the patient needs to be here for the transthoracic. Okay? Otherwise, you don't get that 90 degrees from each other. So again, the point of that is take a look at your AP. It's going to pop up real quick. And if it's, obviously broken, just go back into the room, go ahead and shoot your lateral. However it is that you're going to do your lateral before you have your patient relax their arm. Okay? Questions on upper extremity? I should finish this thing. Because we've got about 30 minutes. So then your shoulder girdle, we have, fundamentally, we have two bones. All right. So we've got the clavicle, which is your collarbone, and we've got the scapula, which is your shoulder blade. All right. So the only bony union that you have between your upper extremity and your trunk is this little thing right there. Right. And that's what this is your the upper portion of your sternum. That's your manubrium. That's what you call your sternoclavicular joint. So that's that knot that you've got right here. Okay, that's the only bony union you've got there, and it's fibrous. It moves, and it's got tendinous attachment. It moves quite a bit. So our most common fractures in our shoulder are going to be broken clavicle, separated shoulder, dislocated shoulder. Separated shoulder and dislocated shoulder are two totally different things, and we'll talk about those when we get there. All right, so the shoulder girdle articulates the head, uh, the head of the humerus within what we refer to as the glenoid fossa, and that is the socket portion of the scapula. The other articulations, again, are going to be your manubrium to the sternoclavicular joint, and then you've got a AC joint too. We're just going to refer to that as the SC joint. Your AC joint, this is the acromion process of your clavicle or of your scapula and our clavicle, again, it's called. So dislocated shoulder has to do with the removal of the ball from the ball and socket joint. Probably more common, I'd say, more common. I've seen more of that. A separated shoulder, though, is disarticulation at the AC joint. So when you hear like football players have a separated shoulder, they're not talking about dislocated shoulder. They're talking about that ligamentous attachment there is separated on some level. So it's widened to some point. And I think they grade it 1 through 4. Number 4 means that all attachment is just ripped and it's just free floating at that point. The grade 1 is just a slight separation. It's kind of stretched out. Okay. All right, so it's diarthritic joint, ball and socket tight, yada, yada, yada. So clavicle, the difficulty that we run into in getting good x-rays of clavicles is it's impossible to get two views 90 degrees from each other on clavicle. So we're going to do something a little bit different from clavicle, and it should look a little bit familiar to you. It's basically shooting a lordotic chest. And for the most part, we're going to accomplish that by using central ray angulation rather than having the patient lean back. Double curve, all that is really just more information than what we need. And so the posterior portion of the shoulder girdle. So you've got this ridge of bone on the posterior portion of your shoulder girdle, and then you've got a lot of muscle, fat, and tendons that kind of fill in this gap. The reason I've mentioned that is going to be, I'll explain it here in just a bit. But on the lateral side, so you got two different borders. On the lateral side, you've got what we refer to as the, and it's puffy side, this side over here. That's what we refer to as the axial border. And then this is the vertebral border. So you can tell the difference between the two because this might be, I don't know. I don't think it's quite a half an inch wide, but it's pretty puffy as opposed to this side. The vertebral border is almost a pencil fine line. So the significance of that, we'll talk about the significance of that here in a bit too. All right. So all the same stuff applies. So we're still at 40 inches. We're going to get to 72 inches for one view here in a bit. Radiation protection, all the same stuff we talked about before. So our essential projections for a shoulder, we're going to have internal, external, and now we're going to have neutral rotation. The positioning, again, for the AP shoulder is going to be pretty much identical to the positioning of the AP of the humerus. The only difference, again, is going to be two things, those being central ray location, collimations. Those are the only differences. Internal rotation is the same internal rotation we talked about before. External rotation is the same external rotation we talked about before. Neutral position is just with the palm of the hand up against the thigh. All right, so we're going to talk about all that. We're going to talk about the Gracie method. We already talked about the transthoracic. That is what we refer to as the Lawrence method. There is an inferior superior axial. That's also a Lawrence method. And then we're going to talk about scapular Y, which is a much better view than the transthoracic. We'll talk about that here in a bit. Okay. So I'm not going to spend a whole lot of time on the AP projections because we talked about that in humerus. Again, just externally rotate. That puts the greater tubercle in profile. The main difference here is your collimated field should be about a 10 by 12. Okay, your scapula isn't that long, so your 12-inch dimension is going to be to make sure that you include the medial end of the clavicle. Okay, so it's going to be 12 this way, 10 this way. Okay, so 10 by 12 image receptor size. Let's see, outline of greater tubercle, and then your central ray location is going to be about 1 inch inferior to the porcoid process. So remember, porcoid process is the any kind of process looks kind of like a beak. I wish I had a skeleton down here. I just didn't have enough arms to bring a skeleton. But on the anterior portion of your scapula, you got this thing that looks like a beak. Right, and that's this round thing right here. And you can kind of feel where that is if you mash on your shoulder. You got the deltoid muscle, and you got your anterior whatever. But if you go just medial to that, where your fingers kind of sink in the most, that's where that's going to be. Okay, so your central ray location is going to be on that, just an inch inferior to it. All right. So that's your central ray location. Collimation is going to be 10 by 12. Central ray location is going to be there. Internal rotation is going to give us the lesser tubercle on the medial side. External rotation is going to give us greater tubercle on the outer side, on the lateral side. Right. Your neutral rotation just doesn't show you either one of those. That's your external rotation. And then that's your neutral rotation. Honestly, I don't see the point. I don't think it shows you anything that the other two don't. Your Gracie method, though, can be very useful. All right, so you notice this neutral position. You have some superimposition between your humeral head and your glenoid fossa. Glenoid fossa, again, being the socket portion of the ball and socket joint. It's full of sprouts. On the external rotation, you've got superimposition. Internal rotation, you got superimposition, right? So if you need to see the joint space, what we're going to do is we're going to rotate the patient towards the image receptor. So about a 45-degree oblique, and it really kind of depends on the patient's body flow, but towards the side, the affected side. So what we're attempting to do is your glenoid fossa sits at an angle kind of like this, right? And we've got the ball portion of the ball and socket joint. So what we're trying to do is we're trying to rotate to where they separate. Okay, so that's your Gracie method. Some people refer to it as true AP. Not sure why, but you may hear somebody refer to it as that. But the purpose for the Gracie method is to visualize the joint space, the glenohumeral joint space. All right, so It's spelled exactly the way it sounds, glenoid control joint space. But it's that thing. It's the joint space between the ball and the socket portion of the shoulder. Okay. Thoracic, we already talked about. All right. So then let's talk about, we're going to skip over the axial. And we're going to go scapular Y. We'll come back to the so your Y view. I back up to one of the APs. 90, statistically speaking, 95%, I think it is, of your shoulder dislocations is going to be anterior dislocations. There's going to be obvious deformity. Anybody ever dislocated shoulder? Okay. So if you looked in the mirror, what you saw is your shoulder was kind of saggy, right? Your patient's going to come in holding their arm. They're going to be slunched over, and there's going to be obvious deformity. The shoulder is going to be low, right? So 95% are going to be anterior. What that means is they're going to pop out, and they're not only going to come down lower, but they're going to come kind of medial as well. So the shoulder, the ball portion of the ball and socket joint is going to be situated, instead of right over the glenoid fossa, it's going to be like right here. Okay, patient's going to be in a lot of pain, not really going to be wanting to move it all that much. 5% are going to be posterior. My clinical experience, I've never seen one of them. So with the Y view, what our objective is on the Y view is to take the scapula, put it lateral to the image receptor. Okay, so what you have on your scapula is you got the body of the scapula, you got your AC joint, and you got the coracoid process, right? You got those ridges as well. But what it looks like then is you got this triangular looking thing, and you got some projections off of it. So you got coracoid process here, you got the AC joint here, the clavicle comes across and articulates that way. That's a really bad scapula. But whenever we put it perpendicular, you got so you got vertebra over here, right? You got vertebra over here. This is going to be your thin order, your thin side. That's going to be our axillary border. I'm sorry, that's going to be our vertebral border. Axillary border is over here. So if we take the patient, and regardless of if you shoot at AP or PA, if we take the patient, we oblique them up until those two borders are superimposed, what it's going to look like is that you've got the body completely superimposed, so that you've got, you know, both of those bodies on top of each other, and they're going to come out kind of like this. So that one of these is going to be the acromion, and the other one is going to be the coracoid. Okay, you can tell them apart because with the acromion, you got the clavicle coming across and articulating with it. All right, so you got the vertebral and axillary borders superimposed. You got the acromion sticking out in one direction. You got the coracoid sticking out in the other direction. It looks like a Y. That's why we call it a Y view. Right. So with the Y view, what that also does is it puts the glenoid fossa. The glenoid fossa is going to be right there. Okay. So if the clavicle is coming out this way, then where's the rest of the body? Unless the patient's been in a train wreck, the rest of the body is going to be over here, right? So our ribs are going to be over here, and we shouldn't have any superimposition over between the ribs and the scapula. You should project it out and away from the ribs. So most of our fractures, or most of our dislocations rather, are going to be anterior, so they're going to come out front, and then they're going to go medial a little bit. So what we're going to see then is if the patient has dislocation, it's going to be over here 95% of the time. And again, 0% of the time have I seen the humerus, posterior. So the wide view can clearly demonstrate dislocation without the patient having to move the shoulder at all. All right. So the patient comes in, you shoot the AP, and then you can do this AP or PA. It doesn't matter which one. Our obliquity though now might come up to 60 degrees depending on the patient's body habitus and our body build. So this is the first one that we're going to look at where our oblique is not 45 degrees. It might be 45 degrees, but it might go up to 60. Okay, so past 45 degrees up to 60, you shoot AP. Most people shoot AP. I always shot mine PA. Most people shoot AP. I'm not real sure why. The clavicle, back when we shot on screens and films, looked like it was a foot long because of the magnification. Doesn't really look like that with CR systems because it kind of adjusts everything. But on screens and films, it was massive. So it can be shot AP or PA, either one. Now, this is why I mentioned that ridge of bone across the posterior portion of the scapula. The easiest way for me to position the scapula was always like this. Your textbooks, depending on textbooks, will tell you to take the patient's vertebral border, put your one finger on the vertebral border, one finger on the axillary border, and then oblique the patient until those two things, your two fingers are perpendicular or superimposed. Okay? A lot of problems with that. You can break your scapula. And if you break your scapula, the patient's not going to allow you to just, grab their scapula. That's number one. A lot of people are goosey. Okay? So you start reaching up under somebody's armpit and you're going to have a hard time. They're just going to run from it. Okay? A lot of people, you're going to have a hard time finding my scapula. I'm not as thin and fit as what I used to be, so some people are going to have some soft tissue and you're going to have a hard time getting to it. If you take your hand and you put it on the back side of their scapula and you put your hand perpendicular to the image receptor, you're going to be about 5 degrees away from perpendicular. The scapula is going to be about 5 degrees away from perpendicular. 5 degrees is not much. Why do I say 5 degrees? Because all this down in here is going to be filled up with stuff. Okay? But from PA, if we're shooting PA oblique, from PA, we're going to rotate up the patient until my hand's perpendicular, lay my hand across the back of the scapula, rotate the patient up until my hand's perpendicular, and then rotate them towards prone about 5 degrees. And again, that's from here to there. Very minimal. And you got to get a good one every time. Okay? So from AP, you can, essentially do the same thing. From AP, you would have to go more towards lateral. So rotate them up a little bit further. So it'd be the same thing. Okay? So we can see a lot from this. Okay, what if a patient had a fracture across the scapula? Do you think you could visualize that? You think you could visualize, let's say the patient didn't have a dislocated shoulder, but they had a broken humerus. Do you think you could see that better than through lung tissue? Yeah, probably 5 ribs. Yeah, good. So what do you think the radiation dose to the patient is going to be going through this much material as opposed to this much material? A lot less, right? So your radiation dose can go down. You can see a broken humerus, you can see a broken scapula, you can see a dislocated shoulder all off of this one view. Okay? Really recommend this over, the other views. So there is a difference though. If the patient has a broken scapula, the scapula again is going to be real thin. And if you put that thin bone and superimpose on it a thick bone like the humerus, might it cover up the fracture of the scapula? The answer is yeah. So if you have a fracture of the humerus, is the scapula going to pose a problem? The answer is probably. You're probably still going to see the fracture of the humerus, but you might not see the fracture of the scapula. So how could you do a wide view to diagnose a fracture of the scapula? Move the arm a little bit, right? Yeah, so you're doing your wide view, and instead of having the arm hanging down like that, just move it one direction or the other just a little bit. It doesn't have to be much. And whichever way is easier and more comfortable for the patient, you can have them put it back, you can have them put it up, doesn't matter. Just get it out of the way. So the only difference between the wide view for the humerus and wide view for the scapula is position of the humerus. That's it. That's it. Right. Just wide view. That's a good wide view. So you got clavicle here, right? It's coming all the way out. You can't really see. It's a little dark up here, so you can't really see where it actually touches. But the chromium process not only comes up, but it also makes a turn. So that's your AC joint. Then you've got your coracoid process, and you've got your the body of the scapula almost perfectly superimposed. It looks like we might have a fracture of the humeral head. So, you know, if that's where your humeral fracture is, it really doesn't matter if you move the arm or not. You know, you're not going to desuperimpose that. But again, if it's a fracture of the humerus, you don't necessarily have to move it anyway. Okay. So let's go back and talk about the other Lawrence method, and that is our inferior superior axial projection. So this one's a little bit complicated. Patient has, I'm just going to go ahead and say, has to be on, you know, on a table, on a bed. I tried to do this up, standing up, and never had any success whatsoever out of it. Some people have, but I have not. So a few things with this one. The patient has to be able to move their arm, so they're going to abduct the arm out to 90 degrees from the body, if at all possible. So 90 degrees right angle, right? So patients laying on their back, have the image receptor above their shoulder, and you can have the patient hang on to the image receptor. Okay. And what you're trying to see is the glenohumeral joint space from the glenohumeral joint space here down to as much of the humerus as, you know, as reasonable. So what you're going to do is you're going to angle your central ray 30 degrees towards the patient's head, essentially. Okay. So what's the most radiosensitive part of your body? Yeah, your eyes. Your brain, not so much, but your eyes. So how could you protect your eyes? How could you protect the patient's eyes? The brain is really not radiosensitive, but the eyes are, and the thyroid is. So how could you get those out of the line of fire, so to speak? Yeah, have a patient look in the opposite direction, right? So now if it gets to the eyes, it's going through the head, which is not, you know, radio sensitive anyway. Also, though, what you're going to do is you're going to have the patient look in the opposite direction and also tilt the head. Now notice what happens between my image receptor and my neck as I tilt my head in that direction. What happens? Increase the distance. So what you're going to do is after the patient does that, push that image receptor in further. If you don't do that, then you're probably not going to get the head of the humerus. Okay? So patient looks in the opposite direction, tilts their head in the opposite direction, image receptor above the shoulder, central ray 30 degrees medially. Okay? So if the patient can't get their arm out to 90 degrees, then you're just going to decrease the angulation. So if they're at 45 degrees, you might use 20 degrees. It's not going to be ideal, but again, we got to sometimes adjust to what the patient can and can't do. This one's not all that great. This is pretty much a textbook version.
Quick question.
Yep.
I always forget when degrees are involved. You line up and then do the degree, or is it you do the degree on the tube and then you line up where you need to go?
Do the degree on the tube and then line.
Because that way
Yeah.
you know where you're aiming for.
Right, right. So if you position and
Then
then,
do it. It's gonna be all off.
yeah, it's going to be completely off.
Yeah.
So you're going to learn, you know, right now it's going to be pretty mechanical
Mhm.
for you. You're going to go step by step by step, and sooner or later you're just going to get to a point where it's fluid, where it's just going to be one motion.
Mhm.
But yeah, do the degrees first, and then do your alignment. Yep. Oh, and another thing, I know it's kind of a rabbit trail, but later in the semester we're going to do spines. And so for some of our spines, our you know, our frontal views, our central ray is going to be perpendicular, and some of the views we're going to have angulation. Okay. What you've got to remember to do, kind of along the same lines, and the reason I'm thinking about this is what you've got to do is, let's say you shoot, one of the views is what we refer to as an open mouth odontoid. So to see the very top of the C-spine, we got to go through the open mouth. So the central ray is going to be perpendicular. And a lot of times what we'll do is we'll do the open mouth odontoid and then we'll do the AP, but the AP is an AP axial, right? So what you might do is do the open mouth odontoid, and then you turn and it's 15-degree angulation. You turn 15 degrees. Okay, so imagine, you know, your central ray is perpendicular, right? So you're centered to the middle of the image receptor for the AP, and then you put 15 degrees on the central ray. Where's your image receptor? Yeah. So when you know, change your angulation, make sure that you also consider your image receptor and realign it.
Mhm.
Otherwise, you know, you can be projecting into the floor. So is everybody good with everything so far? I think we only have one thing left to do. We don't. We got one. Okay. Well, do we have any questions? I think I'll just record the rest of this. Any questions?
So when we like center to a Y, do we just center it to the middle of the scapula?
Yeah. Yeah. Any questions? Any others? And for the Lawrence method, the inferior superior axial, you just center the joint space, so it's flowing right up into the armpit. So that some people will shoot that, and they'll put the image receptor on the tabletop, and they'll go superior inferior, and they'll angle, you know, towards the elbow essentially. I've tried this over and over again, and I've had zero success with it. Some people are aces with it. I've never hit it, not even one time. So I just stopped. So, you know, if it works for you, it works for you. I couldn't make it work. All right, then I'm going to stop this recording here, and then, you know, I'll start another one. If you want to stick around, stick around. If you don't, then that's okay too. I figure if I stop the recording.